Thank you for inviting me. I love talking about this topic. Of all the ones talks I gave, this is my favorite one. That's my disclosure slide. I receive rewards for abiraterone. That's probably the most relevant. So to align on the patient group I'm going to talk about, question 1, mets on CT or bone scan, no. Is the patient at high risk of having metastatic disease? Yes. And I'll talk about PSMA PET. I'll give you the headline opinion. If a patient has metastatic disease that we're missing and is going to live long enough to die from prostate cancer, we will statistically prolong his life by treating with ADT and then RP. We have evidence for abiraterone. I think we'll soon have evidence for other AR antagonists. This is not a question about treatment, what treatment to use. It's a question about prognostication. In my talk, I'll first present data we published a couple of years ago, which is slowly having an impact globally, entering clinical practice globally. And then I'll present new data, which is not yet ready for clinical implementation, but could suggest a way forward for improved prognostication. Now, PSMA PET, as the first speaker already very elegantly explained, we now increasingly have patients with metastasis on PSMA PET. We often do not have a bone scan or CT scan. We have the CT component, but we often don't have a bone scan. And we have to make a treatment decision. And the principle stays the same. If your patient is going to die from prostate cancer, and he's hot on PSMA PET, so you can see distant mets, you've made the assessment he's going to die from prostate cancer, he's likely to benefit from intensification. What we do not yet know is who or how to assess the likelihood of death from prostate cancer based on PSMA PET, because we don't have enough data at this point. So there's going to be some extrapolation and multidisciplinary discussion to make that decision. There's clearly equipoise. So I'll focus on where we have level 1 evidence, and that's in the STAMPEDE trial. This was designed in 2004, and you'll see the criteria there are very much what you would have used in 2004. The trial actually included any patient who was starting long-term androgen deprivation as defined for 3 years or longer. This included metastatic patients. It included non-metastatic patients who met these criteria, either node positive or if node negative, at least 2 of these 3 high-risk factors. Over time, I guess, 2016, 2017, we started to recognize that the M1, the outcomes for these M0 patients were different from M1. So we split them. And that's what we do now. We'd really refer to these M0 patients differently. A footnote is that the trial was primarily newly diagnosed patients receiving primary therapy. There was a small group of patients who are relapsed. And that's because we did use long-term hormone therapy for relapsed patients. And I'll talk a bit about that at the end. They were all treated with radiotherapy, or the vast majority were treated with radiotherapy to the prostate. We allowed enrollment even if prostate radiotherapy was excluded for other reasons. We mandated radiotherapy to the lymph nodes in N0, and that's where you can see 99% receive radiotherapy, and we strongly encouraged it for the node positive. When the trial was recruiting, the evidence wasn't strong enough for radiotherapy to node positive patients. You can see the median age and PSA there, and in the whole trial, 40% were node positive. So the primary result, many of you will have seen this, this was a very positive result. It seems obvious now. When I look at it, I say, obviously, if you have a really high-risk group of patients where at least half are going to die from prostate cancer, you give them a drug which works effectively, and they're going to die from prostate cancer because they have distant mets. They're not relapsing from their local disease. You're treating their local disease with radiotherapy, but you're insufficiently treating their metastatic disease with ADT alone. You add on abiraterone in this case, you're going to prolong time to distant mets, and improved survival. The endpoint of MFS is a surrogate of OS. It's very closely aligned with OS because MFS is time to distant mets or death from any cause. That's important. It's not death from prostate cancer. It cuts your trial back by about 9 to 12 months. That's what we see in STAMPEDE. And some patients die from prostate cancer without having CT scans, as you'd expect in busy clinical practices. So there's a very clear and consistent benefit. You can see here the 6-year MFS was improved from 69% to 82%. Now, to be able to report sooner than if we had just waiting for the abiraterone trial, in the STAMPEDE platform protocol, we had 2 trials that ran sequentially. So first recruited patients or randomized patients, ADT, ABI, and 6 months later, we started to randomize patients ADT versus ADT, ABI plus ENZA. So we could ask 2 questions and also report much sooner. We combined them using meta-analysis approaches, and you can see that there is no difference between, in MFS, for the patients randomized to ABI or the patients randomized to ABI and ENZA. Because the ABI and ENZA trials started after, you have shorter follow-up. That's why the KM plots are clipped sooner. The interaction hazard ratio, you can see there, no difference in effect. So you see that you have clear benefit for MFS for an ABI combination regimen, and you have no difference. ENZA only introduces toxicity, both clinical and, of course, financial. When we look by subgroup, firstly, I'll just address one thing. You'll always wonder, why is the NSAIDs in there and aspirin? It drives me crazy that it's there. But when the platform trial started, it had celecoxib. So that was a stratification variable. So it's really helpful, actually, because to highlight the potential chaos subgroup analysis causes. With NSAID, the NSAID subgroup always goes in every possible way. So you need to be really careful how you interpret subgroup analysis, and that's really highlighted as you see across all our studies, NSAIDs, where often there's no biological rationale for a difference in that subgroup. But anyway, focusing on the one which is relevant, nodal status, consistent benefit, and I'll talk about that a bit more. But clearly, if you have a node-negative population who are unlikely to have distant mets, unlikely to die from prostate cancer, and you give them a drug that's going to cause some toxicity and long-term complications, you're not going to help them. So you need a really select group of high-risk, node-negative patients. Overall survival was a secondary endpoint in this analysis. We powered for 0.75 hazard ratio. I remember spending many months worrying about that because I used to review the death forms, and there were so many patients who died from another cause. Ultimately, we had overpowered. And in terms of death from any cause, you can see 60% of patients died from prostate cancer on the ADT arm, 50% on the combination arm. I would argue we effectively cured 10, 12%. Now, that's a big word. And can you say, they've cured? But those are patients who died from something else without having died or relapsed from their prostate cancer. And yes, you'll appreciate this is a very high-risk population. 60% on ADT have died from prostate cancer. As you'd expect from that information, the hazard ratio for prostate cancer-specific survival is stronger. And prostate cancer-specific endpoints are all stronger because for OS, you've got a proportion who've not died from prostate cancer. So to conclude, I think this has permeated most of the guidelines. If you have a very high risk, non-metastatic patient by conventional imaging, you should combine with 2 years of abiraterone. We don't have good long-term follow-up, so we do not yet fully understand the long-term implications, and there will be. We have no data on treatment durations other than 2 years. This was very much chosen arbitrarily, and it's been done for all the trials. Will shorter be as effective? Will longer be more effective? Relapsed patients, I said this, are underrepresented. I think this has now been addressed by the EMBARK trial. A high-risk relapsed population will benefit from treatment intensification. We don't have evidence for single-agent AR antagonists. This will come, I think, very soon, and within the next 6 to 12 months, we'll see efficacy there. And of course, combination with surgery, and I think Proteus has already been mentioned. So the burning question is, how far to the left can you go and still statistically help your patient prolong their survival? And as you've seen, we included only very high-risk patients. If you use NCCN high risk, for example, that includes a larger group. And the AR antagonist trials have aligned with NCCN high risk. So we really, I guess, wait to see what's that going to show. How far to the left can you go? Now, to try and address this, we've performed a number of ancillary trials on the patients in the trial. I'll present one of these experiments, which we presented at ASCO a few weeks ago, and it was published concurrently in Lancet Digital Health. We worked with a biotech called Artera that takes images of the H&D slides together with some clinical data and generates a score. This was developed in earlier disease, so low and intermediate risk, where the question was to treat or not to treat. So not to intensify or not to intensify, but to treat or not to treat. In terms of the clinical variables, we've now realized that if you just take the images, you have a better prognosticator. So future tools will only use images. Clinical variables like Gleason, PSA just added confusion, added noise. Now this will be improved with time. So in this very high risk population, as you'd expect, the scores are much higher. So you generate this continuous score. That's the distribution. You see the dotted lines there represent to the classifiers for an earlier risk population, which, as I said, is to treat or not to treat. And the majority of STAMPEDE very high risk patients, 89%, are in the MMAI high score. As you'd expect, using this as a continuous, well, not as you'd expect, I guess, because it's a different population. But at least we first showed in this population, the continuous score associates with all clinical endpoints. So MFS, prostate cancer specific mortality, and time to distant metastasis. So now the question is, how can we use this to make a treatment intensification decision? We worked through a number of cut points. This starts to become arbitrary, and I say, okay, we just need to use one thing that's obvious and not fish around too much. And we used quartiles. So higher quartiles, so the top 1/4 versus the remaining 3/4. And you can see there, the blue line is the top quarter, the red line is the lower 3/4. This is strongly prognostic in the M0 population. But key is, can it help us inform a treatment decision? So as you'd expect, the upper quartile group are much more likely to die from prostate cancer. The lower 3/4 are less likely. So the benefit of combining with abiraterone is potentially less, and you can see that represented by the two hazard ratios there. And when you, I guess, compare that for all those endpoints and perform an interaction p-value, we do see a significant interaction between the biomarker test and the treatment effect. So the effect of abiraterone is stronger in the upper quartile group. It's not predicting cancers that are more biologically sensitive to AR inhibition. It's predicting who is more likely to die from prostate cancer versus not die from prostate cancer. And probably this will be most helpful in the node-negative population, which again you see here. The hazard ratios have slipped off my slide, but the hazard ratio is significantly lower in the upper quartile and pretty close to 1 in the lower 3 quartiles, N0, M0. Now this is a very high-risk population. This starts to tell you, okay, if we're going to start including any high-risk patient, or any PSMA PET positive patient who does not meet these very high risk criteria, we're going to overtreat. Now, of course, there's other balances. Age, concomitant medical illnesses, there's going to be equipoise here, and we're not going to generate that data for PSMA PET, so we're going to have to use clinical judgment. Of course, the limitation with my last few slides is that this was a discovery set. This will need to be prospectively validated. I hope we will in the AR antagonist trials. And the cut point will probably be at around this point. And that's my last slide. Bang on time. Thank you.